This was a study evaluating the use of systemic bevacizumab in a mostly older adult and late elderly population who had non-HHT related vascular anomalies causing severe bleeding in their intestines. So this includes people with acquired von Willebrand syndrome, with von Willebrand disease, with chronic disease, and with idiopathic angiodysplasia. And it's very common for this is a very common problem overall, and it's very common for these patients to have really substantial bleeding requiring dependence on intravenous iron or sometimes red cell transfusions. And people, like right now, the standard of care is to go in and do local ablation with argon plasma coagulation and clipping and things like this of the lesions. But all of these conditions have an underlying angiogenic dysregulation, such that there's excessive angiogenic signal. And the more tissue injury you do, as in patients with HHT, the more lesions you provoke to grow, right? So we see this clinically. You go in, you cauterize, you do whatever you can, but then a few months later, the bleeding is back and it's often worse than it was before. The only drug therapy that is really used with significance in these patients is octreotide and other somatostatin analogs. This reduces splanchnic blood flow to reduce the rate of bleeding, but does not actually address the underlying lesions. And so, for many, if not most of these patients, current approaches are quite less than adequate, particularly for the patients that have severe bleeding. And so, recognizing that, like HHT, these patients have an angiogenic problem, and recognizing that bevacizumab has been shown to be efficacious at treating GI vascular lesions in HHT, this study is an evaluation of an off-label bevacizumab treatment pathway that we instituted at the Massachusetts General Hospital HHT Center of Excellence for patients without HHT, right? For people who have these other causes of vascular bleeding. And the bottom line of the study is that low-dose bevacizumab given at 5 milligram per kilogram or 2.5 milligram per kilogram in people older than 80 or who had really substantial pre-existing comorbidities was highly efficacious in reducing bleeding or even eliminating bleeding from these lesions by causing, right, it causes involution of the lesions, and if they're not there or not prominent, they don't bleed. And it reduced the amount of hematologic support required. Of the median amount of hematologic support required in the cohort was over 14 red cell unit equivalents, as a combination of both red cell units given and intravenous iron given, as something called the Hematologic Support Score, measured in red cell unit equivalents, from 14 red cell unit equivalents in the 6 months prior to treatment to about 4 in the first 6 months after treatment, and 0.5 in the second 6 months after treatment, months 7 through 12. So really a dramatic improvement. And not only that, right, it reduced hospitalizations and emergency department visits specifically due to vascular GI bleeding in these patients profoundly by over 50% in the year after versus the year before starting bevacizumab. And it did it pretty safely, right? So bevacizumab's main side effects are hypertension and proteinuria. And certainly those were seen in about 30% of the patients. 30% of the patients each, I should say. 3 of the patients had to discontinue for grade 3 proteinuria, which is clinically relevant proteinuria. But the rest of them were able to be managed and monitored. And, proteinuria tends to get better with dose reduction of bevacizumab. Hypertension can be treated with medication. And so most patients were able to deal with those side effects, come off of red cell transfusions, come off of IV iron infusions, or only need IV iron every so often, stay out of the hospital, stay out of the emergency department with, monthly to every 2-month low dose bevacizumab infusion. That's a great question. It's due to probably a number of things. Number one, right, some of the patients did drop out who didn't respond. About 20% of patients didn't respond. So those patients would have dropped out during the first 6 months, which then make the results in the second 6 months a little bit better because those patients didn't respond. So that's important to note. But also very important to note, what tends to happen even in responders, right? You achieve hemostasis by starting bevacizumab and administering it during an induction period where you give four infusions every 2 weeks. Um, but then, right, patients are still iron deplete, right? So you have to refill the tank. The tank isn't leaking anymore, but it's empty. So you have to refill it with some intravenous iron. And so that's what most of the red cell unit equivalents during that first 6 months was made up of, was really filling the tank. And beyond that first 6 months, right, in the majority of patients who were nice responders, they didn't really need much beyond that because they were full and they weren't bleeding anymore. So that's really likely what we're looking at. But the longer we treat patients, just anecdotally, the study didn't look at people's GI tracts with follow-up endoscopies or anything like that because that's an invasive thing and we don't do it unless it's really necessary. But when it was done for one reason or another, right, we tend to see that, GAVE lesions, gastric, antral, vascular, ectasia lesions, the angiodysplastic lesions throughout the intestines, whatever it is, they've shrunk down. They're much less prominent or they're gone. Absolutely. So a lot of it is risk stratification at baseline. So if somebody starts with baseline significant hypertension on more than one antihypertensive medication, I would start that person at 2.5 milligram per kilogram. I'd keep a close eye on their blood pressure. You always check their blood pressure before every infusion. You also check their urine dipstick, right? Their urinalysis before every infusion to see if they have significant protein. Someone who starts with no protein is more likely to remain without protein. Someone who starts with a little bit of protein is more likely to develop more significant proteinuria, right? So people who start with some of these things, even if they're more mild, I err on the side of starting at a lower dose. People who don't, I start at the more typical 5 milligram per kilogram dose that we use in HHT. It's really just monitoring. If someone develops bad proteinuria and you stop the drug, they will normalize eventually. You just have to give them time, give things time to go back to the way they were before. And I would say if someone is grade 1 or grade 2 proteinuria, really proteinuria up to about 2,000 milligrams per day on a urine spot protein creatinine ratio, you can monitor that person. It's not nephrotic range proteinuria. It's not ideal, but given the alternative, um, just about every nephrologist that I've talked to is very happy to just say, okay, totally fine for them to have that proteinuria. Let's monitor it. It's great that they're not in and out of the hospital anymore. It's great that their hemoglobin isn't 7 anymore. We'd rather keep that, going than stop for a laboratory abnormality. But you can always lower the dose from 5 to 2.5 or even from 2.5 to 1.25 milligram per kilogram with an infusion and see if they maintain their response. Many patients do maintain their response with lower doses.